So I'm talking about burns because it's something that is sort of near and dear to all our hearts working at Rahima. We see a lot of pediatric burns, unfortunately. Why is it relevant? Well, there are so many deaths globally associated with burns. And the burden of injury in South Africa is really high as well. Lots of these patients actually need specialized burn services. One scary statistic that I got from WHO is that children under 5 in the WHO Africa region have more than twice the incidence of burn deaths than children under 5 worldwide. What about dedicated burn units in South Africa? We've got about 17 burn units. They aren't necessarily dedicated burn units. They might be very well hospitals that have burn capacity, and they are able to sort of allocate specific beds to burns. There's about 218 beds around the country for peds burns. So this is sort of how the beds are allocated according to provinces. And you can see we've got a really high number of beds in Gauteng, with almost equal numbers adult to ped, and some of the particular burns units can admit adults and peds, and it's not specialized to adult or peds. It's a mixed burns unit. Yeah, and that's how we get kind of to the numbers of around about 218 burn beds around the country. What about in Gauteng? Well, we've got 5 hospitals that can admit burn patients. George Macquarie Hospital in Pretoria, or in Tshwane, is able to admit 32 patients, both adult and ped. They're not specifically dedicated adult or ped beds, so it's 32, but shared between adults and kids. Kalafang can admit about 20 patients, 10 adults, 10 children. Tembisa can admit in total about 10 patients with burns, and it's sort of mixed adult pediatric beds. In Barrow, they've got 20 beds for adults in the burns unit, and peds, they've got 24. They usually work on 4 or 5, depending on availability of staff and availability of cubicles for sort of peds burn ICU patients. So their peds burn ward at Barrow can admit sort of normal burns with small percentage burns, but they also have a dedicated peds burns ICU. And then Laratong has got 28 beds for adults and 10 for children, but they do not have the same specialized services that the burns unit at Barrow has. Okay, so if we're looking at the burn units sort of for our referral area, Joburg and Krugersdorp, it's a real specialized burns unit at Barrow because there's pediatric surgery, with pediatric intensivists, pediatric anesthetists. It's multidisciplinary. There's also just a normal burns ward. They've got a dedicated burns theatre. They do need to share the theatre complex with the adult burns, but they at least have an area that is dedicated for this. They've got dedicated ICU beds and specialized equipment, as opposed to the Laratong's burns ward, where they have 10 beds, but there's only one plastic surgery registrar looking after the patients with an intern, and they very well might have a junior ComServe or MO for that year. So it is a dedicated burns ward, but there's no dedicated burns theatre, ICU. There's no specialized pediatric anesthetists, no pediatric intensivists. So it's not really multidisciplinary. Although they do, both centers do use the allies, and the allies are very helpful. So dietitians, OTs, physios, they just don't compare. And so you'll kind of understand why when we've got really severe burns, Laratong will often turn us down. They just don't have the same support. And if they want to get patients to theatre, essentially it's their normal theatre lists, which they already struggle to get patients to. So what about Rahima? Well, we all well know at Rahima that we don't have access to surgeons. We don't have a burns unit. We spend many hours of our day referring children with burns, at least to be seen at Simja for follow-up, or even with the plastic surgeons or with the pediatric surgeons, depending on the areas involved. And we often find ourselves admitting cases, patients with special areas, maybe the child has special needs, they've got other comorbidities, or a high percentage of burns while we're waiting for the beds to open up and become available at the other units. So what is the function of skin? Well, it's a very important organ that we often do not discuss. It's a protective organ. Involved in temperature regulation. It's also got an immunological function, so it's protective, and has got a lot of sensory organs in it, and is sort of the first barrier against trauma, pathogens, UV light. It's also got a lot of sensory organs in it, and it prevents the loss of fluid and is involved in homeostasis. So it's an important organ. When it's damaged, it's understandable that patients can get really sick. Okay, so how do we then sort of have a look at the old terminology, which was first degree, second degree, and third degree burns? So first degree is now known as partial thickness. Sorry, let me just go there. So superficial burns. Second degree is partial thickness, and you'll either have a superficial partial thickness or a deep partial thickness. And often at the time of the injury, it's hard for us to tell which kind of burn it is, but it's important to see how many structures are involved. Your hair follicles, nerves, oil glands, and subcutaneous tissue, and it's why it's so sore. Full thickness burns is where the dermis, the entire layer, is involved. Fourth degree, so that's when essentially muscle down to bone is burned. Fortunately, we don't see so many of those, but very often the big burns units will. Okay, so how do we heal? Parts of the skin that heal better are the areas that have got hair follicles and other adnexy. So if you've got an area that's rich in adnexy, this area re-epithelializes very nicely. A dry wound heals by scarring. A moist wound actually contributes to epithelialization. So we do like to have moist wounds, and it's why it's nice to use stuff like Granuflex as part of your dressings. Okay, I like this slide. Amy did it for us a few years ago when she did her talk. What do we define a burn as? Well, it's injury to tissues caused by contact with heat, flames, chemicals, electricity, or radiation. Now, we're not going to talk about chemical burns or radiation. We're going to touch mostly on thermal injuries and a little bit on electrical. So thermal injuries can be from hot liquids, can be water, but actually can also be hot oil, hot solids, open flame. And thermal burns are the most common whether you're a child or an adult. So what is the difference sort of in presentation across the world between small people, so peds, and adults? Well, we do know that kids have got much more, they present much more often with scalds and contact injuries, less likely to have chemical and electrical, whereas adults are more likely to present. They also present with scalds and contact burns, but when you look at the percentage of adults to children, the older age groups are more likely to be involved in flame and explosions, contact and electrical, but particularly it also might be occupational related. So this is just another chart showing how when you're really small, the sort of the biggest number of burns is contributed to scalds. And as the kids get older and start exploring and being more mobile and more independent, so their distribution of injuries or types of burns changes and becomes more typical of an adult burn, like when they are 11 to 12 years old. So the age groups also differ. In our setting at Rahima, so cooking, either cooking with electricity or cooking on open flames, actually it's hot water is the biggest contributed to burns in our environment. All of these cause issues. And it's not just the families with no access to formal electricity. It is families who have electrical stoves, electrical kettles, and those are pulled over the kids. These were our burn stats from 2023. Amy collected these really nicely for us, and I've used these stats to motivate for additional resources, and I'm still begging for a pediatric surgeon So we see a lot of burns. We admitted quite a few. The transferred were mostly transferred from the ward, but we also obviously do a lot of referrals as well. And this number, you can see the total burns visits. The same kids come back for multiple dressings because the clinics are under-resourced. They often don't have Gelinet, they often don't have Meloderm, they definitely don't have Irixol, and frequently the children don't get procedural sedation and analgesia. They'll get Panado and Brufen analgesia, and the parents themselves find it quite inhumane and bring the kids to the ED at Rahima because they know they get slightly better care with dressings. Okay, so with kids, we see a lot more hot water burns than flame burns, and this is true of our patient population in South Africa, but in particular at Rahima as well. What about electric burns? Well, I'm not going to go through this in a huge amount of detail. Just want to remind you guys that this is a really nice infographic or flow chart. It's really important to look at the kind of voltage. So around the house, even if it's an insecure cable or insecure electrical line, it's still most likely going to be a low voltage. Depending on how high the voltage is will determine how worried you are about the patient. So a kiddie that comes through and you know they put their finger into a normal plug, they'll often present with finger burn and maybe a foot burn somewhere else. Still go have a look and do a good head to toe exam. Don't just focus on the burn. I find often people are so worried about, well, this is a potential finger amputation, that they don't go ahead and look for other fractures and injuries elsewhere. It's a good idea to do an ECG, especially if you're not sure about the voltage, and a urine dipsticks, because you might see hemoglobin showing kidney injury, but also because hemoglobin is how myoglobin presents. So if the child was exposed to a fairly high voltage for a long duration of time, the patient also then might have had contractures or contracting muscles during the exposure to the electricity, and can have hemoglobinuria and myoglobinuria and resulting crash injury as well. The high voltage cases, usually these are the patients that will demise before they reach us. So if there's sort of overhead lines where people are stealing unsafe electricity or borrowing from a neighbor, but they're taking from the main line, or if there's actually at a high voltage electrical exchange where people go in to try and steal copper. This is more likely to be adults also because of occupational exposure, but we do have children that come in also, unfortunately, in cardiac arrest due to electrical injuries. Depending on the level of injury, if we're really worried about high voltage, do an ECG, you might need to do troponins, maybe you need to do an echo, and depending on what kind of abnormalities there might be dysrhythmias, ST elevations, troponin leak. It really just depends on how the patient is presenting. Okay, so what about burn shock? What exactly is it? Well, we get a massive hypovolemic shock associated with burns. That's also a distributive shock. And there will also be a concomitant cardiogenic shock. And this is how patients can present hypotensive, tachycardic, and really clapped out in the ED. And patients die of burn shock. So there's a massive surge in response to the burns because it's a really significant injury. So obviously the larger the burn, the larger the burn shock. And the surge further worsens the distributive shock, causes vasodilatation, and you get leaky capillaries, the massive release of cytokines, and the cytokines themselves can then go and further injure the heart and can cause subsequent cardiogenic shock as well. So not only is the patient vasodilated, they're tachycardic, but they're not necessarily producing a really good cardiac output. Associated with all of this and the leaky capillaries is also the edema. All of these can lead to multi-organ dysfunction, multi-organ failure, and death. And when a patient is really in the cycle of burn shock, it's very difficult to resuscitate them out of it, which is why we have to pay such huge attention to the resuscitation of burns. Just another way of looking at it is this pathophysiology showing burn edema and hypovolemia. And it's kind of going through the same stuff that I sort of demonstrated on the slides, but you're also losing your integrity of the interstitial space as well. So not only do you have leaky capillaries, but the interstitium is incredibly affected as well. And for that reason, there's a significant change in your fluids and fluid shifts. So how do we resuscitate a burns patient? Well, ABCD approach that we really love in emergency medicine. Okay, so do your primary survey. So looking at the airway, if the patient's got significant flame burns, mouth burns, tongue burns, this patient needs to have an airway secured early before the edema gets worse. And before their airway becomes closed, so they might need intubation. It's very rare for a patient needing intubation if there's a scald injury. It's highly unlikely unless it's a massive percentage and they're actually going into multi-organ dysfunction. You might need to supplement the oxygen, might need to BVM them if we're having to tube them, and you might need to ventilate. The big thing that we need to do as part of the primary survey is to look at circulation. Maybe they've got hemorrhage as a result of other injuries with their burns, but actually they've probably got burn shock. So we need to look at their fluid losses and sort it out as much as possible. Try and present a secondary brain injuries. So they might have had a hypoglycemic incident because it took a while to get from their home or the clinic to the hospital. Maybe they have other injuries as part of how they got their burn in the first place. Have to expose them, and this unfortunately puts them at risk of hypothermia. And we want to make sure that we get the patients warmed up once we've exposed and dressed all their wounds. Okay, so attention to fluids, analgesia, whatever tests you need to do. We usually want to do a urine dipsticks and venous blood gas in the emergency department. However, if you think you're going to need to transfuse the patient, maybe you need to do a compat. Okay, a full history with details of the injuries, and then a good head-to-toe exam. Please remember to have a look at the tetanus vaccination status of the child. If you're unsure, make sure that you vaccinate. There's no harm in giving a booster, but there's definitely harm in not giving tetanus vaccination if the vaccinations are not up to date. Okay, secondary survey means ongoing head-to-toe exam, and you very well might need to repeat your ABCD exam primary survey as things change. Okay, then for us, very important documentation and then organizing transfer of the patient. Okay, first aid that might be done before the patient gets to us. The mum very well might have done something to cool the patient. Ideally, cooling, so if it's an immediate burn, pop the child's hands or the exposed limb under the normal running tap for 20 minutes. That's the magic number for cooling. In South Africa, they still seem to love using burn shield. It's a first aid dressing. It's not a hospital dressing. So burn shield can be used sort of by your little local clinic. Maybe EMS has put on burn shield and then transported the patient to hospital. Or somebody at home has sprayed on the topical burn shield. But you must take off the burn shield for two reasons. Burn shield itself is not a burns dressing. It delays healing. And secondly, if it's ingested, it's highly toxic and can actually kill patients. So we don't really like the tea tree oil so much, especially if it's ingested. Okay, our priorities of care, please analgesia as soon as you can via whatever measures, oral, intranasal, intramuscular, IV, or multimodal. Get the analgesia into the kid, particularly before you even open up the burns. You need to establish IV or IO access as quickly as possible. And if it's extensive burns, so more than about 15%, you definitely need to put up central access. Okay, and then look at your temperature control. Okay, how do we estimate the total body surface area? Well, it's really nice to use the rule of nines, like in this picture. We have got different charts in the ED, so in our protocols. You can either use the Lunt and Browder charts, which shows the different percentages based on the age, or the rule of nines. Now, the Lunt and Browder chart is much more exact. These two slides or these two pictures here are from our protocol book that shows what can we use for analgesia for burns, what do we do for looking after the wound. So you do need to clean the wound with clean water, sterile saline if you have available sterile water, but even if you're washing a big burn underneath a running tap. that's good. There's a lot of debate about should we de-roof the burns, and one of the reasons that you do need to scrub the burn is it's really difficult for us to correctly estimate the body surface area until we have actually had a look. So we often will take pictures at the beginning because the burn is progressing depending on how we resuscitate the patient. And pictures sort of on day one when they present to us, and then pictures the next day or the day after, because the burn very well does extend. And maybe you have underestimated the burn size initially, because you couldn't necessarily see significant burn, and then down the line, it's actually larger than what you estimated. These are little pictures that we have in the emergency department that you can use. Please do these and draw the surface area of the burn, so fill it in. This is an awesome app, the eBurn app. The one that I've got is French, but to be honest, it really doesn't matter because it shows you 1st degree, 2nd degree, 3rd degree burns, and you can actually color in, and it'll tell you how much of each percentage is burnt. And it will also help you then guide your fluids as well. Okay, so if you are admitting burns patients, for us, it will depend what we admit, but we prefer the patients to go to a burns unit or a ped surgeon or a plastic surgeon, just essentially somebody that can assist us with the burns. However, if you do need to admit the patient, it's a good idea to add on additional vitamins. Multivitamin is the least of the supplementation. Please do have a look at zinc, folate, and we only sort of add iron when the wounds are mostly healed and there's little chance of infection. Okay, so estimating the burns depth, I find that people are not necessarily very good at estimating burns surface area, myself included, just by looking at it. You really do need to draw it out, map it out visually or using an app. Even worse, even in our department, is estimating the burn depth. Superficial burns we often don't even see. These are patients who might have sunburn. It's quite sore, it's red, but there's no blisters. Superficial or deep partial thickness. These are actually usually pretty sore. The superficial partial thickness is often what we see with our scalds, where the fluid sort of pours off the patient quickly. And often this heals really nicely. The deep partial thickness is, for example, like a contact burn where they've had hot porridge that sat on them and taken a bit of time to be wiped off. More likely to form scars, and very often these burns do need some sort of surgery. Okay, full thickness burns, those have to be sent to a surgeon. They're dry, they're white, they're leathery. So please, guys, when you are estimating your burn depth, this is really important because it also helps us to prognosticate. These, it doesn't matter what dressings you put on there, nothing is going to get rid of that thick eschar on top of the burn. Very often they have to do an extensive debridement, and the patient will need to have skin grafting afterwards. When there's 4th degree, this is really bad because it's all the way down to muscle and bone, and these patients have significant tissue loss and might need significant help from plastics down the line for reconstructive surgery and to prevent contractures. Okay, there's a system called Benheim classification, which we've essentially just been talking about. And you might find in different parts of the world, especially in South America, they call superficial partial thickness type A, partial thickness AB, full thickness B, 4th degree type C. This just helps when you're reading articles from different parts of the world to kind of understand what they're saying when they're describing different kinds of burns. Okay. Depending on the depth of the burn, the worse the depth, the deeper the burn, the worse the prognosis. So this is essentially what this graph shows. Okay, there's different formulae that you can use for resuscitating a patient. So I also like this slide. This was from one of Amy's talks as well that she did a while ago for us. We've got Parkland's formula, modified Parkland's, Brooks formula, modified Brooks, and there's quite a few formulae. Essentially, we're probably going to start with 3 mils per kg times by the total body surface area. You'll note that this formula doesn't take into consideration the depth of the burn or if there's airway burns, inhalation burns. So we'll still do it according to half over the half of the volume over the first 8 hours, and it's the 8 hours taken from the time of the burn, not the time of presentation to hospital. And then the remaining half of the volume is given over 16 hours. And it's why in our department, we'll often keep the patient in the ED until they've finished their Parkland's formula. Because up in the ward, even if you run an infusion pump, it will often stop an alarm and nobody calls us, and you'll get up there and the patient hasn't had their fluids at all, or the drip has tissued. So it's really important to have a look at this. It's the starting point. If you find that the patient's gas is worsening and their cap refill is really bad, you've obviously underestimated the volume requirement for this patient. So then you will up the volume of fluids and adjust it accordingly. If the patient is looking really puffy and their chest is starting to sound crackly and their urine output is ridiculously high, you then will obviously taper down. Now, there's no reason why we can't give some of that fluid orally. The problem is that patients who've got severe burns are often very sore, and it's hard for a child to feed, whether it be boob or bottle, when they're in excruciating pain. So it's really important to make sure that there's excellent analgesia. I did a talk before on procedural sedation and analgesia, and I'm going to suggest that you guys refer to that for the analgesic requirements, because that's a little bit beyond the scope of this talk. Just have a look at the protocol, though. Obviously, if the patient's urine output is tapering, you very well might need to up the dose of fluids. Okay, cover the burns, and depending on where you're working, if you're working in private, they've got the most amazing dressings. In state, we don't always have a lot. Paraffin-based dressings apply directly to the burn wound. So paraffin dressings have got Vaseline in them. Vaseline is a paraffin dressing. Vaseline is an excellent topical agent to put onto burns. Okay, we don't put gauze straight onto the burns because it sticks to the burn, and then when you pull off the gauze, it really hurts. Flamazine is what all the local clinics and district hospitals and Rahima has. It's not the best dressing. You'll find that Flamazine itself, if you're using large volumes, can also inhibit epithelialization. But it is one of the things that we can use to keep the wound moist. Chloromax will apply to facial burns, and we're using it not for the chloromycetin, we're using it for the petroleum paraffin-based medium. So we're using it because it's the Vaseline. That's what we want to use. Okay, if we need to debride, if the wound is a bit sloughy on follow-up visit, you might need to use Melodermin or Rixil. You'll never use those on a first presentation if it's a fresh burn. It's different if it's a first presentation with us and the burn happened 2 weeks ago. Those wounds very well might be requiring some desloughing. Okay, look for signs of non-accidental injuries and look for specific burn marks that will guide your suspicion of a non-accidental injury, and also might give a clue as to what surface might have been used to burn the child. So cigarette burns, immersion burns, maybe they actually applied an iron to the patient. Maybe somebody had a curling iron or a straightener and they used that to burn the child. Okay, look at the distribution. If they're a big enough kiddie that their bum can actually touch the bottom of and sort of nicely compress against the bottom of the bath with boiling water, you might see preserved buttocks. Look for splashes and the patterns. Also look for the stocking and glove, because that's where the little hands and feet have been put into the burning water. Okay, I'm not going to talk a lot about inhalation injury, but please, if you've got a suspicion of airway burns, you very well, and that's usually flame burns, a patient has been burnt in an enclosed space, you need to attend to the airway. The patient doesn't necessarily have airway burns that's only upper. They can have lower airway burns and present with wheezing and acute lung injury, where all those toxins, the PVC, all of the volatile poisons that are released can damage the lungs as well, not just the thermal heat injury. Okay, so look at your carbon monoxide levels on your blood gas and look for a high lactate as well. These are highly suspicious in an inhalation injury. So your carbon monoxide levels will be high if they've been in an enclosed space. And if you're suspicious about a cyanide toxicity, those patients often have these really high lactates that don't come down even with fluid resuscitation. You need to be suspicious about cyanide toxicity. And then you need to, if they're worried about cyanide toxicity, you need to go and look at giving a cyano kit and actually managing the cyanide poisoning. Okay, which patients do we refer to a burns unit? These are according to the Burns Society of South Africa. So all burns in patients less than 1 year of age, burns where they're little kiddies and the burns are more than 5%, any age group where they're third degree, because unfortunately a clinic and a small hospital isn't necessarily able to cope with those. Kids that have got more than 10% total body surface area, you'll often find in the very big centers, they've upped this value to 15%. And that's purely based on they've got so many patients and not enough beds. So though technically it is 10%, we'll find ourselves admitting patients with 15, 16, 17% burns to look after them because we don't have access to a bed for them. Okay, special areas, so hands, feet, face, perineum, genitalia, major joints, especially if it's circumferential. Okay, patients with electrical burns and lightning burns, those patients ideally should also be referred. Doesn't necessarily mean they'll be accepted because there frequently isn't a bed. So then we'll need to admit those kids. Okay, chemical burns, especially if they're ingested chemicals, but that's a different matter entirely. Inhalation injuries, circumferential burns around the limb or the chest, because it can impair breathing and ventilation of the patient. Okay, patients who've got pre-existing medical conditions, especially if they're severe, like SAM, those patients need to be co-managed with pediatrics. Ideally, it would be great to have a pediatric intensivist as well as the ped surgeon in a burn unit. If we have kids like that or who've got severe epilepsy or intellectual disability, then we need to contact the rest of the team. So peds and the allieds need to be involved early. Okay, so if there's concomitant trauma, especially if it's actual significant trauma with fractures, and depending on the mechanism, where child abuse is suspected, please don't ever send those kids home because we do need to refer to the social workers and the police. Okay, where the treatment exceeds the capabilities of the referring center. And that's always us. We have taken 4 years to get Melodome. I'm very grateful to Dr. Tahir for sort of organizing them to get it always. And then septic burns as well, sepsis, septic shock. Okay, once you've got a patient that you've resuscitated, given adequate analgesia, maybe put up a urine catheter, you've monitored, you've given your first 24 hours of fluids, for example, in the ED, and these kids now need to be admitted. So we need to optimize, obviously, our referrals to whichever speciality is involved. But don't forget the allieds. Speech, we don't always think about involving them. We're really good at involving OT, physio, dietitians, usually as an afterthought. But don't forget about looking at speech therapy, especially if we're looking at swallowing. They usually can sort of help us when we need to look at sort of moving away from nasogastric feeds to oral feeds. And then don't forget about all the other stuff, psychology down the line for the parents, for the child as well. They very well might have problems with school and need further support. Okay, and then depending on the patient, maybe they need social workers and police. Please have a look at your fast hugs because this is helpful for sick patients, especially severe burns. Okay, we've got different phases of the burn injury, and what we usually are faced with is phase 1. So when the patient arrives, we're trying to sort of stop the burn, stop the injuries, prevent further injury, resuscitate their fluids, look at their urine output, make sure that their urine is a good urine output. So for adults, we'd usually consider 0.5 mils per kg adequate, but for a kid, you usually want 1 to 2 mils per kg. And 0.5 is the lowest that you'll allow it to go. Okay, fluid resuscitation. So we'll go on ongoing maintenance fluids and adding oral feeds as fluids for the next 48, up to 48 hours. Burn coverage, and that doesn't just mean the local dressings that we do to actually try and get the patients to getting surgical cover. So burn wound excision, grafting, or using a skin substitute. So in private, they've got amazing skin substitutes. So they cannot use post-mortem, so cadaver skin. They can mesh your own skin. They also have really fancy spray-on skin that they can use in private. Okay, phase 4 can be a long time. So supportive and critical care, but this, depending on the condition of the patient, can take a long time. Okay, and then rehab can take up for years. The psychological stuff can take a long time. And the SIRS that you get associated with a burn, the patient might have a tachycardia and a raised respiratory rate just because of how catabolic this state is. It's such a high energy using injury that the patient very well might remain in a SIRS for up to 12 months, even 18 months after a burn. Okay, what about the complications? And I love this, Amy summarized it so nicely. They're the early complications, so hypovolemic shock, acute injury, acute kidney injury, acute lung injury, significant electrolyte disturbances, infection, so it'll happen a few days down the line, especially if we haven't kept the burn wound clean. Maybe they get a paralytic ileus, either from the actual injury or as a subsequent result of all the morphine that we give the patient, and maybe they get stress ulcers. Okay, later down the line, maybe they have scarring, contractures, psychological trauma, and both of them, acute and late, kids can die. Okay, what about the relationship between the total body surface area and mortality? Well, the higher the percentage body surface area burned, the higher mortality. And this is an old graph from, I'm trying to think, when was the 1960s? No, 1940s. And although burn care has improved in various parts of the world and where you're working, where we work, the management of burns is still very rural because we just don't have access to surgeons. Okay, so this is, it also shows the older the patient, the lower the percentage burn is still associated with a very high mortality. So the very old age group, the older you are more likely to have a higher mortality, even with the smaller percentage burn. The in-between age group, so if you're middle-aged, you don't have as high a mortality for the same percentage burn. Adolescents, actually, it's usually protective. What they didn't include on this graph is because it wasn't specifically a pediatric graph. Under the age of 15 years, there's also a higher mortality as well. Not 15, under the age of 5 years, I beg your pardon, there's also a higher mortality. 5 to 15, the adolescents, so kids and adolescents, it's usually fairly protective. All right, so there was a more recent study, this was done in 2017, which shows pretty much the same thing. The higher the total body surface area, the higher the mortality. So that's a finding that they sort of documented in the 1940s, and it's still true now in 2024. Okay, what about actually in South Africa? So stats from South Africa. At Barra Burns Unit, and this is a specialized pediatric burns unit with all the peds, surgeons, and intensivists. No child with a burn injury of more than 60% total body surface area survived. So that's just something to think about. If you have a patient who's got a really high percentage of burn, you need to already start talking to the parents about you need to know that the prognosis for these injuries is very poor. This is a team that is able to scrub the patient in theater and get early coverage. This is a team that's able to ventilate patients. They're able to dialyze patients. They have early access to grafting, early access to surgeons. And even in this unit, the mortality for the high percentage total body surface area burns was high. Okay, so that was more for me. So what is the LA50? So it's the lethal area 50 index. So essentially it's kind of like, it's similar to the toxic dose 50 or the lethal dose for pharmacology. So it is the extent of the burn total body surface area associated with 50% mortality. Most places in South Africa don't actually report their LA50 index, but usually patients that come from low-income countries or low-middle-income countries have got less resources. So those patients have got a lower LA50, so a lower total body total body surface area percentage associated with 50% mortality. And I found one study that has been published in South Africa where they actually looked at the LA50. So this was in Pelanomi, so it's in the Free State. They've got a unit that admits both children and adults, pediatric patients and adults, and their total LA50 was 37%. So that means that patients with 37% total body surface area, half of those patients are going to die. So it's kind of an indicator of how their unit is doing. I can't find the LA50 reported for anywhere else in South Africa, but it is reported internationally, often very well in first world countries. And you'll find in first world countries like Sweden or Finland, burns will have a LA50 of 65, possibly even 70%, just because their access to resources is much higher. There are lots of different prediction tools to assist with predicting the likelihood of mortality in burns patients. The traditional score from the 1970s is the Baillie score. So that's where you add the patient's age to the total body surface area. For example, if you have a child that has 60% burns and they're 6 years old, you'll have a Baillie score of 66. What is often misunderstood is that the score actually isn't the percentage risk or probability of death. A score of more than 75 on the Baillie score is associated with almost certain probability of death. The Baillie score of 90 has a 50% probability of death. The Baillie score has been modified over the years to look at the protective value of childhood, so between the ages of 5 and 15. Actually, you would minus the patient's age. If there is an inhalation associated, you then have to add 17 or 18, depending on which version of the modified Baillie score you used. There are lots of other different scoring systems, so the acute burn severity index, the Bobby index, the Flames, the Garcia index, many, many more. Okay, so what are some of our predictors of mortality? So high surface area, if there's flame burns, if you're less than 5 years old, older patients, so geriatric patients, and the older geriatrics, or the older you get, the higher your mortality. Females, unfortunately, have a higher mortality than males. The depth, so if you've got a superficial burn, your survival is great. But if you've got a really deep burn, that's also something to bear in mind. It also directly is linked to mortality. If you've got airway burns that have required ventilation, even if it's ventilatory support, for example, high flow nasal oxygen versus full-on ventilation. If there's malnutrition or other underlying comorbidities, depending on our infection control measures up front or sort of ongoing as well. So in the ward, how are we preventing cross-contamination? If there's established sepsis, the length of stay also points towards mortality as well. The higher the length of stay, often the higher morbidity and the higher mortality. But very importantly, where we work, access to burn services. Scalds have the highest LA50 and the lowest standardized mortality rate. So that's also something to bear in mind. If you've got contact burns, flame burns, they will have a much lower LA50. So that's the problem with some of these predictive tools. They don't necessarily include the depth. They don't necessarily include the mode or cause of the burn. And they don't take that into consideration. These are not helpful for us in the ED. They're more helpful prognostication down the line for admitted patients or patients in ICU. If you are dealing with a patient who's got severe burns, please, you do need to already start getting the family ready for there's a high chance that he or she might not survive. You need to talk about what are we going to do if the kitty goes into end organ failure. And you need to start talking about end-of-life care, especially if your patients come in with 50 to 60% burns in the ED. You need to start getting the family ready and prepare them early It doesn't help to have these unrealistic expectations, and then they're really angry when the child dies. And don't forget, although we spend a lot of time counseling the family, is debrief your team. Tell your team, look, the chances of survival for this patient is really poor, and chat to them, because it's really heartbreaking when you have to go through this end of life stuff with patients. So probably the most important part in the chain of survival for patients with burns is burn prevention. This is a really cool poster from the Red Cross Children's Hospital in Cape Town, looking at some of the first aid things, some of the statistics, what to do in case of a burn, and really trying to promote burns prevention. I'm going to leave you with a quote from The God of Small Things by Arundhati Roy. There really is no such thing as the voiceless. They are only the deliberately silenced or the preferably unheard.